Welcome to the presentation for Nursing 150, Module 6, Care of the Patient with Activity Needs. I do apologize for the background of this PowerPoint. I'm not sure why the background changed as I loaded it into the program to do the recording. It's probably a good idea to print off the PowerPoint that is posted and use that as you go through this presentation. Concepts related to this module regarding patients' mobility needs basically is going to be related to their mobility. Those are the problems that the patient's going to have, and those are the concepts that we sort of have to kind of focus on as nurses. Their mobility, we're going to have to do interventions in order to maintain their mobility as best we can with their disorders with the musculoskeletal system. We have to be able to identify needs of pain control and how we as nurses can intervene in order to make sure they have pain control. And then sensory perceptions if there's any neurovascular issues that arise related to their mobility issues. This is a list of physical assessments that are required to determine a patient's mobility and sensory perception. A lot of it has to do with their ability to perform their activities of daily living independently. It has to do with whether they have range of motion of their joints. Do they have pain with range of motion? Do they have crepitus, which is that kind of crunching noise in a joint when they do range of motion? Do they have swelling of their joints? Is there swelling in the extremity at all? Is there, can they perform ambulation without assistive devices? Things like that is our assessment to determine whether patients are having a activity need. This is just a picture of some of those range of motion activities that we'll have the patient do in order to determine if they are having activity and mobility disorders. And that's just looking especially like, doing a motion like this. Is there swelling in the joint? Is there crepitus when they move the joint? Are they having pain when they do that? That kind of identifies for us whether they're having an issue with their mobility. Make sure you review just a little bit of the anatomy and physiology regarding joints, regarding the way bone is made, related to long bones, short bones, types of structures of bones. That's all in your book. You can kind of review all of that. There is some cultural things in your book that's kind of interesting. The fact that your ethnicity can determine how tall you are. It can determine some of your bone density issues. Things like that, so it's kind of interesting to know. For instance, it says African Americans have a greater bone density than Europeans, Asians, and Hispanics, and they have a decreased incidence of osteoporosis, so kind of interesting things. This slide is talking about diagnostic tests related to determining mobility and sensory perception issues. So, of course, calcium levels are going to determine people's bone density. We need enough calcium in order to have strong bones. Other things to make sure you review is the fact that the muscular system is connected with the musculoskeletal system. We have to make sure that they have healthy muscles as well as healthy bones. Tendons and ligaments are associated with sprains and strains, and we'll talk about that shortly. But basically, having strong muscles contributes to the fact that we have a healthy musculoskeletal system. There are some changes that occur as we grow older. There's a good table of that in your book. Osteopenia is a word that refers to a decreased bone density that occurs as one ages. Many older adults, especially white, thin women, have a tendency to have severe osteopenia, which leads to an osteoporosis. which we'll talk about in the next few slides. Continued assessment is just patient history, nutrition, monitoring, making sure they're getting adequate nutrition, history of any kind of fractures, any kind of arthritis, family history. Current health problems can be associated with a musculoskeletal problem, any medications that they might be taking. Posture and gait, we're going to be looking at that to look for any kind of curvature in their spine, things like that. Typically, diagnostic testing starts with the typical x-ray. The skeleton can be viewed with a standard x-ray, especially if we're suspecting a fracture. That can be diagnosed pretty quickly with just a standard x-ray. Of course, CT scan can be used to identify a little bit more diagnostic issues if we can't see it on a basic x-ray. Arthroscope can be used as a diagnostic test or a surgical procedure. It's basically a scope, fiber optic tube that can do direct visualization of a ligament or articular surface of the joint. That takes a little patient prep. Basically, it can be done ambulatory or same-day surgery, but it is more invasive. I already mentioned calcium and vitamin D levels. We know that vitamin D is directly related to the absorption of calcium from the diet, so we need to make sure they have adequate vitamin D intake. Vitamin D intake and absorption requires sunlight. So people who live in areas such as the Midwest who have times of very short exposure to sunlight can have vitamin D deficiencies, which can lead to a calcium deficiency. We'll talk about rheumatoid factor with rheumatoid arthritis. That is a blood test that can identify whether a patient has the rheumatoid factor leading to a rheumatoid arthritis, which is an autoimmune disease. And uric acid is a diagnostic tool to determine whether someone has a buildup of uric acid, which can lead to gout. Osteoporosis is a metabolic issue related to bone strength. The result of osteoporosis is bone mineral density decreased, so it's a weak bone essentially, and it's due to the fact that osteoclastic activity, which is bone resorption or kind of the breakdown of bone, is greater than osteoblastic activity, which is referring to bone building. So we're breaking down quicker than we're building. And the essential thing to understand is that bone is constantly undergoing changes. It's called bone remodeling. And so this bone remodeling peaks at ages 25 to 30. And during this time, the osteoclastic activity and osteoblastic activity are at their peak, and they're working well together. After that peak at age 30, bone resorption activity exceeds the bone building activity, and this affects bone density. And that's why a lot of times they'll tell women ages 25 to 30 they need to really build up their stores of calcium, because that's really when it starts. At age 30 is when that time of risk for bone resorption to exceed bone building occurs. One thing to understand is that estrogen is associated with bone loss. So estrogen doesn't build bone, but it does help prevent bone loss. So postmenopausal women become exceedingly at risk for having osteoporosis. There are several comorbidities that are associated with osteoporosis as well. Those are listed in your book. They're things like hyperthyroidism, hyperparathyroidism, Cushing's, HIV, cirrhosis, bone cancer. And we know that there are some medications that can lead to an osteoporosis. corticosteroids being one. Loop diuretics can lead to it. Immunosuppressants, cytotoxic agents such as some of your chemotherapies. So it's important to know that can put a patient at risk as well. There is osteoporosis is classified as either primary or secondary. Primary is much more common. It occurs in postmenopausal women and in men. Usually men are more at risk, but it's usually later in life. It's typically their 7th or 8th decade. So women become at risk for it around age 30. Men, it's usually age 70 to 80 that they become more at risk. And then your secondary causes are those ones that are typically related to those comorbidities, hyperparathyroidism, long-term drug therapy. So basically, they're secondary to another issue is why they're called secondary causes of osteoporosis. So in summary, risk factors for osteoporosis, older age, history of it, it does tend to run in families. It can be your gender, your genetic makeup. Low body weight, thin build are typically at risk. A smoker, of course, high alcohol intake, and lack of physical exercise. This is just a visual picture of the effects of osteoporosis. So you can see here, this is the bone is much less dense, and it would be much more fragile in this state right here. These are some of the changes that can occur, and especially in women. You see their ages right here. It basically the compression due to the weak bone, and they tend to lose height as they age. A patient with osteoporosis does. There are lots of known relationships with nutrition and osteoporosis. Excessive caffeine is thought to decrease calcium because it causes calcium loss in your urine. Because caffeine is a diuretic, so it's thought to high calcium intake can increase the loss of calcium through urine. Diet lacking vitamin D, which stimulates the parathyroid gland to produce calcium from the bone matrix. Vitamin D is needed for calcium uptake in the body. Anybody that has any malabsorption issues are going to have potential for low serum calcium. And we talked about that with some of the GI patients. We know that there are some GI patients that can have some malabsorption issues. So those people could be at risk for having osteoporosis. Calcium loss also is known to occur more with a high phosphorus intake. They're known to be inversely related. So the higher your phosphorus, the lower your calcium. The lower your phosphorus, the higher your calcium. What a lot of people don't know is that carbonated drinks, such as soda, has a high level of phosphorus, and a lot of them they have caffeine in them. So carbonated beverage has high amount of caffeine, it has high amount of phosphorus, and those people who drink large amounts of carbonated beverages with caffeine and phosphorus in them can put themselves at risk for an osteoporosis. Osteoporosis results in more than 1.5 million fragility fractures each year. Fractures as a result of osteoporosis and falling can decrease a patient's mobility and quality of life. So they can be pretty serious disease. Mortality rate for older patients with hip fractures is very high, just because it can be very debilitating and hard to recover from. So for diagnosis of osteoporosis, of course, it's going to be that health history, talking to them about their diet intake, and talking to them whether they have any signs or symptoms, such as kyphosis, any pain in their back, have they lost inches, things like that. Conventional x-rays can show some bone density, decreased bone density. However, it doesn't show on x-ray until 25 to 40% of the bone loss has occurred. Of course, if they have a fracture related to osteoporosis that can be seen on x-ray. The most commonly used screening and diagnostic tool for measuring bone mineral density is the what's known as a dual x-ray absorptiometry, which is also known as a DEXA scan, DEXA. And that is a specific test that can tell us a bone density. It is the best tool out there that we have right now to determine a definitive diagnosis of osteoporosis. It's painless, it's easy, it's essentially like an x-ray and actually doesn't even produce the same amount of radiation. They basically take their height prior to performing the test. The patient is asked to remove any metallic objects before the scan, and then it is essentially done like an x-ray. Treatment for osteoporosis is going to start again with nutrition therapy, talking to them about their nutrition and defining what changes we need to make. If they're not getting enough calcium intake, we need to increase that. If they have excessive alcohol and caffeine consumption, we need to talk to them about that and see if we can make those changes. Lifestyle changes, more activity, losing weight are all important aspects of treating osteoporosis. Drug therapy, calcium supplements are a good way to decrease the incidence of osteoporosis. Again, it has to be identified early and treated early. They do recommend that most women have a DEXA scan by the age of 40. That way they can go ahead and determine if they're having any bone density loss, and they can begin to take supplements. Calcium supplements are most readily utilized by the body when they are fasting and immobile, so it could be not a bad idea to take them at bedtime. And encourage fluids. We know that encouraging fluids is always a healthy thing, and then it can prevent them from getting kidney stones. And then monitor their calcium levels. Biophosphates are some newer drugs that have been put on the market to help with, to prevent bone loss and increase bone density. That is their mechanism. They are not associated with calcium levels. They are essentially there to prevent bone loss and increase bone density. The important thing to know about biophosphates is they can cause esophagitis. So there's very specific instructions for how and when to take biophosphates. Biophosphates must be taken on an empty stomach. They have to be taken first thing in the morning with a full glass of water. Take it 30 minutes before food and drink. And then after they take it, they have to remain upright for 30 minutes after taking it and make sure their fluid intake is good. This is all done to prevent them from getting an esophagitis related to the biophosphate meds. Estrogen replacement can also be utilized in the event that they determine a patient is experiencing osteoporosis related to postmenopausal loss of estrogen. This is just a quick slide to just make sure we're all on the same page. Your book states that calcium normal levels is 9 to 10.5. And those we make sure that we have an idea of the normal level of calcium so we can determine if someone's at risk for developing osteoporosis. Nursing care for a patient with osteoporosis is essentially aimed at prevention, especially if we're talking to 30 years old. Peak bone mass is achieved about 30 years old in most women. Building strong bone as a young person may be the best defense against osteoporosis in later adulthood. So nursing care for younger adults is teaching them about prevention. Helping them to prevent those modifiable risk factors, making sure they get enough dietary calcium, dairy products, dark green leafy vegetables. Teach them to read food labels for sources of calcium content. Teach them to just be aware. Also, the vitamin D supplements, and making sure they get some sun exposure, and they are also eating calcium fortified foods. They need to try to avoid carbonated beverages as well. Make sure they're active. Teach them about the signs and symptoms of osteoporosis. If they're, which cannot be always detected. Usually in a younger person, the beginning signs of osteoporosis can go unnoticed. But again, you could teach them about how it's recommended by most providers now that they get a DEXA screening at age 40. Paget's disease is another form of a metabolic bone disease, and it's essentially chronic metabolic disorder in which the bone is excessively broken down and reformed, and this results in a structurally disorganized bone structure. The bones are weak, and they have an increased risk for bowing of the long bones, and they have an increased risk for fractures. Paget's disease is second only to osteoporosis, is one of the most common bone diseases in the United States. It affects about 1 million people. A lot of people don't know that they have it. They don't have any symptoms. Sometimes it's not obviously noticeable, and it can be accidentally found during a routine lab or x-ray exam. Key features of Paget's disease is found in your book. There's a chart in your book that you can look at. Bone and joint pain. They tend to have a lot more pain than a patient with osteoporosis. They have low back, sciatic nerve pain, bowing of long bones. They can have an enlarged, thick skull, pathologic fractures, which means fractures that occur due to kind of secondary to another bone process. They can have lethargy, gout, hyperparathyroidism. You'll learn in Module 7 that your thyroid and your hyperparathyroid do work in controlling the levels of calcium in your bone and your blood. Tricky thing about Paget's disease, like I said, it can be accidentally found. If somebody's complaining of chronic bone pain, this might warrant a further investigation, which would be a conversation about their past medical history, their family history, because it does tend to run in families. Any fractures, any recent fractures, if they've had a lot of fractures in their life. Doesn't really include their diet due to the fact that this is not a diet-related problem. This is more of a metabolic genetic disease. Calcium levels can be either high or low, unfortunately, just because it's difficult, because they have such high and low levels of growth and resorption, and it's really not affected by their diet intake of calcium. It's more of a metabolic issue. X-rays are typically the best way to determine malignant deformities, fractures, and secondary arthritic changes to Paget's disease. Interventions. The drug therapy for Paget's disease is typically oral biophosphates are the first line of treatment. The biophosphates work in regulating the reabsorption and breakdown of bone. The patients may also be placed on calcium supplements depending on their diet conditions, and that's just to support strong bones. It really is not the first line of treatment for Paget's because they need to have a medication on board that will help regulate the metabolic process of their bone building and breakdown. But like I said, the calcium can be added as a supplement to promote strong bones. As with other mobility issues, nursing care of these patients is also related to educating them about their disease process, educating them about their medications. Those biophosphates, they have to take it on an empty stomach, and they have to stay upright for at least 30 minutes after taking the medication due to the high risk of esophagitis with those meds. Nursing care is also directed at safety, making sure that they have mobility tools if they need them in order to prevent falls. We need to encourage mobility because we know that that's healthy for lots of other body systems. So it's important that we educate them and make sure that they have assistive devices if needed, and that we educate them on how to use those assistive devices safely. Osteomyelitis is infection of the bony tissue. This is a very serious infection, and it can be very difficult to treat. It can result in a chronic recurrence of the infection, loss of function and mobility, can lead to a possible need for an amputation and even death. Osteomyelitis can occur as an exogenous way, which means it's an organism that enters the body from some outside of the body, so it's some kind of an opening like a surgery or an open fracture. Endogenous osteomyelitis means that there were organisms that were carried by the bloodstream from other areas, kind of like a urosepsis type thing. An untreated urosepsis could take a bacteria that's already in the body to the bone. One of the more common causes is poor dental hygiene, and periodontal infection can cause bacteria to be spread to the bones of the face. I've seen some pretty nasty periodontal infections that actually affect the bones of the face, can lead to very serious malformations and needs for surgery. A malignant external otitis media, again, is another, which means an ear infection that is untreated and has a certain type of bacteria, could actually lead to the skull bones. Signs and symptoms of osteomyelitis are usually bone pain. A patient shows signs and symptoms of infection such as alteration in their vital signs, especially an increased temp, a general feeling of feeling bad. There's some key features of osteomyelitis listed in your book. It's a good idea to look that over. Again, it's swelling of the area, tenderness, those signs and symptoms of infection that you're used to. Non-surgical management of osteomyelitis includes extensive treatment with antibiotic therapy. It's usually IV antibiotics that the treatment lasts up to 3 months or longer, sometimes if needed. It's important that the patient understands that even if they start to feel better, they have to continue the treatment in order to effectively treat an osteomyelitis. Sometimes they'll even follow the IV antibiotic therapy up with an oral antibiotic therapy for over a longer period of time to ensure that they have treated the osteomyelitis effectively. Surgical management of osteomyelitis might include just debridement. If an area has necrotic tissue due to the bacterial infection and the loss of neurovascular treatment, then possibly they might have to debride, which would mean basically they go in and kind of clean it out and rid the area of the necrotic tissue so that new tissue can heal. Post-operatively, it's sort of similar to your other orthopedic surgeries, basically. Monitoring the wound, monitoring for signs and symptoms of infection, and neurovascular assessment. It's really important to understand with neurovascular assessment, you're looking for any compromise of the nerves to the area or oxygen supply to the area. The 6 P's are the 6 things that are the hallmark of doing a neurovascular assessment. That is pain, pressure, paralysis, paresthesia, which means any abnormal tingling sensation, pallor, or pulselessness. If any of these findings occur, they should be reported immediately to the surgeon. Non-surgical management and surgical management of osteomyelitis was discussed in the last slide. Just the other thing to bring up is that patient education is important. With a patient with osteomyelitis, you need to make sure that they understand that they do have an infection. They need to be doing what they can to prevent any further infections. They should not expose the area to, they shouldn't be getting into lakes, rivers, things like that. They should not be exposed to people who are really sick. and just really kind of participate in the care and making sure that the affected bone heals from the infection and does not get any further infection. Bone tumors may be primary or secondary. So primary meaning that they originate in the bone. Secondary meaning that they are a secondary site, so it's metastasized from somewhere else. Osteo Sarcomas are the types of malignant primary bone tumor. More than 50% of the cases of these types of primary bone tumors occur within the distal femur. Patients with bone cancer present in varied ways. Sometimes if the tumor is large enough that it can compress on the bone and other areas and cause pain and discomfort. Sometimes there's a palpable muscle mass. Sometimes it can cause some disability and impaired mobility due to the pain. And that's usually an advanced case of metastatic bone cancer. Diagnosis is made usually by assessment, getting a patient's history, determining whether they have any history of any kind of cancer, radiation therapy, things like that. X-ray, CT scan are going to help us identify if there is indeed a lesion there. A more specific diagnosis can be made with a biopsy. Metastatic bone cancer can be very, very difficult to kind of deal with. It's very painful. So it's important to make sure we identify it early and treat it early. Treatment is usually aimed at reducing the tumor as best we can. Surgical intervention if it is able to be surgically removed. Treatment of metastatic bone cancer is difficult to cure. A lot of time treatment is palliative versus curative. That means that basically we do what we can to keep the patient comfortable and keep the pain under control. Chemo and radiation are some ways that we can shrink the tumor and decrease the effect of the tumor on the body. I'm going to move on and talk about fractures of the bone. Fracture of the bone is a disruption in the continuity of the bone. Many different classifications of what a fracture is, basically because our bone can break in many different ways. It can be closed and non-displaced. It could be an open compound fracture, which means that the bone breaks in two and then the bone comes out through the skin. Comminuted or fragmented, which means basically that the bone is just broken in many different pieces. Displaced means it's completely moved and displaced. Typically, a bone fracture, if identified accurately and treated appropriately, will heal without causing the patient any trauma. However, the older we get, the longer it does take our bones to heal, and the older we get, the more difficult and painful it can be. We know that bone strength and bone wellness is associated as we get older with our diet intake of calcium and vitamin D. In women, it's affected by the levels of estrogen. There are some complications that can arise from a fracture. Acute Compartment Syndrome, and that's usually related to the healing and the edema inflammation process. This edema process can be complicated further by external forces such as a cast or a bulky wrap around the area. The sites that are usually at risk for compartment syndrome include your long bones, your legs, and your forearms. The complication that compartment syndrome creates is a loss of blood flow to the area, which can cause an ischemic limb and infection. Fat embolism is another complication that can occur related to a patient who has a fractured bone. Essentially, the fat globules that are released from the yellow bone marrow into the bloodstream can almost have the effects of like a blood clot. Typically, they're more at risk for these embolisms 12 to 48 hours after an injury or illness. There's some key features of a fat embolism listed in your book. It's a good idea to review that to make sure you're aware of those complications, because as a nurse, those are the things that we need to kind of be aware of and monitoring for in our patients who have a fracture. Care of the patient with a fracture includes talking to the patient about the cause of the fracture, events leading up to the fracture, any drug history, any diet history, medical history, occupational and recreational activities, nutritional history, of course, and assess them for any life-threatening complications related to their fracture. Make sure neurovascular status is at the top of your list of those assessments. Monitor that fracture site, monitor for pain. And then helping the patient remain safe while they have some mobility restrictions, making sure they have the devices that they need. Splints and other orthopedic devices may be used to immobilize certain areas of the body while they're being allowed to heal. Casts are rigid devices that immobilize an affected body part. The cast allows mobility to some degree while keeping the bone in place while it heals. Traction is the application of a pulling force to a part of the body to provide reduction, alignment, and rest. It's also used to decrease muscle spasm and to prevent or correct deformity in the tissue damage. Skin traction, also known as Buck's traction, is a Velcro boot with a belt and halter secured in place around a body part to decrease painful muscle spasms. Weight is typically applied at 5 to 10 pounds to prevent injury on the skin. Skeletal traction uses pins, wires, or tongs or screws that surgically insert directly into the bone to allow the use of longer traction time and heavier weights. You can use up 15 to 30 pounds in skeletal traction. Care of the patient in traction includes inspecting that skin frequently for signs of irritation or inflammation. Removing when possible, if you're allowed to inspect the skin. Inspect the points of entry if there's pins or wires placed. Follow the policy for pin site care. It's typically just cleaning a couple times a day or as needed. Checking traction equipment to ensure it's proper functioning, and inspecting all ropes, knots, and pulleys at least every 8 hours to make sure that it's all in position. Check the weight for consistency and make sure it's applied as ordered by the provider. Some fractures may require surgery. Usually open reduction with internal fixation is a common surgery. The open reduction allows direct visualization of the fracture site, and internal fixation uses metal pins, screws, or rods to immobilize the fracture during healing. An incision is made to gain access to the broken bone and allow implanting of one or more devices into bone tissue. External fixation involves a fracture reduction and the percutaneous implantation of pins into the bone. I have a few pictures of external fixation here coming up in the next few slides. This is a picture of a Velcro boot using Buck's traction. That is a skin traction. So monitoring the skin, making sure, of course, neurovascular assessment is very important. And then the weights are down here, and making sure that you do not mess with the weights. Make sure the weights are applied as ordered. Again, this is to decrease muscle spasm. And typically it's done maybe 24 hours prior to a surgery to fix the fracture. This is a picture of an external fixation. This is where they've had to reduce the fracture, which means put it back together. And then they've had to apply these pins and this external rods in order to keep it there while it heals. And you can see how important it would be to monitor the site for signs and symptoms of infection. Cleaning the pin sites is a really important part, and making sure it stays clean and it's not exposed to any kind of area that might introduce bacteria. They could end up with an osteomyelitis. For this slide, we will talk about sprains and strains, which are typically injuries to the ligament or the tendon, more of a muscle soft tissue injury as opposed to the bone injury. Sprains are excessive stretching of a ligament. It's usually caused by a twisting motion, such as in falling or stepping on an uneven surface. They are characterized by pain and swelling. Typically, the treatment of choice for these is something called RICE. It's rest, ice, and compression and elevation. That's to reduce the swelling as well as support the joint. It's considered first aid treatment. So it's really the thing that most people have a problem with is actual resting. They need to stay off of it and it'll heal better. Sometimes casting's required just in order to allow the tear to heal. And surgery can be necessary for a severe ligament damage. But just it's important to understand that sprains and strains are usually talking about soft tissue injury as opposed to the bone. Strains, as in a muscle strain, is referring to excessive stretching of the muscle or tendon. Management of that is cold application, exercise with activity limitations, anti-inflammatory medications, and muscle relaxants can be used perhaps for a muscle strain. Makes sense, right? The muscles have been strained, so it's a more of a muscle injury, soft tissue injury. All right, there's multiple things that can cause low back pain in a patient. This can be a muscle strain, as we talked about just in the past slide about a muscle strain or a ligament sprain, and that's damage to the soft tissue supporting the backbone or the vertebral disc. The disc can be affected by degeneration, which is also known as osteoarthritis, or herniation of the center of the disc. And essentially that is in the lumbosacral area, which is your low back. Whenever there's some herniation within the vertebral disc, it can cause pressure on the nerve, the spinal nerve that's associated with that area, which can cause severe burning or stabbing pain, and that can radiate down to their leg or foot. Care of the patient with low back pain can include education regarding the problems that relate and lead to an acute back issue. And this is typically good posture, educating them about using good posture. Exercise can increase your flexibility and strength so that you're at lower risk for having a low back strain. Prevention of a low back injury also includes using safe body mechanics. Do not wear high-heeled shoes, using good posture when sitting and standing. Keep weight within 10% of ideal body weight. Ensure adequate calcium intake, proper vitamin D intake as well. Stop smoking. That can always put a patient at risk for osteoporosis, which can put you at risk for an injury. Osteoarthritis as well is a degeneration of the vertebral disc, so that could put you at risk. So teach them ways to prevent those things from happening, and that can help treat a patient with low back pain. They can also be treated with NSAIDs, pain medications such as acetaminophen. Muscle relaxants can be used for those muscle strains and spasms. Just remember that muscle relaxers make a patient sleepy. Those are typically better taken at night to help them rest. Physical therapy can also be helpful in teaching patients exercise activities to strengthen their back muscles and to prevent osteoarthritis. Surgical intervention can be utilized if conservative measures have failed to relieve the back pain, or if somebody's having severe neurologic effects from any kind of compression on the spinal cord. Two major types of surgeries are used depending on the severity and the exact location of the pain. There's minimally invasive and conventional open surgical procedures. Risk of these surgeries include infection, of course, Sometimes the surgeon will have to actually remove a disc due to a herniated disc, or a fusion can actually stabilize the affected area. Post-operative care is aimed at assisting the patient with their mobility, monitoring for infection, and educating them on activity restriction. Carefully check the patient's neuro status as far as any numbness, tingling, loss of control of bowel or bladder. Those can be concerning post-surgery, because that would indicate possibly somehow it has affected the spinal cord. Sometimes patients might have a drain, such as a Jackson Pratt or a hemovac drain. You always want to monitor the drainage coming out of that and record it every 8 hours at least, unless the surgeon tells you to do it more often. Make sure you're aware of the activity orders for the patient, using correct turning techniques. Utilize the use of PTOT to assist with their teaching and their mobility. Making sure you're preventing them from getting any kind of a DVT. Your book has a table on best practices for prevention of musculoskeletal injuries. Those are some good key features to know in teaching a patient on how to prevent this from happening and from them needing surgery. This concludes the presentation for Module 6 regarding musculoskeletal disorders. There's a few questions here that you can use for practice. I encourage you to do so. The answers to the questions can be found in the comment section of the PowerPoint.